Thanks for giving up your Saturday afternoons. I won't tell you it's really nice outside, but windy. So I'm going to just give a little bit of background and just talk a bit about preconception care, and then I'm going to focus the last part of my talk on genetic screening, because I think that's something that everybody's probably getting lots of questions about. So just I suppose just following really on from Sandra's talk, that we know that lots of women do have significant issues in terms of their general health. So one study showed that about over 3% of women had physical abuse and domestic violence. 18, I reckon it's probably 100% experienced significant stress, but whatever. 1.8% had diabetes, hypertension, anemia, so significant underlying medical problems. And in another study of women who were actually of childbearing age and could conceive, around 3% took drugs that were known to be teratogens, and 4% had a pre-existing medical condition which could significantly affect a pregnancy if it wasn't properly managed prior to pregnancy, and that's really, really important. So we know that over half of maternal deaths in the UK were caused by pre-existing medical conditions from one study, and those included cardiac, neurological and psychiatric. And we're aware, and I'm sure you're all aware, of the increasing contribution from obesity. So in terms of what we talk about in preconception care, there's not actually that much evidence about really, good evidence base, but these are the sorts of interventions that have been identified as being of relevance. So most of you are, intuitively going to be talking to people about folic acid, vaccinations, things like smoking cessation. Maternal PKU is interesting because obviously it's not such a common condition, but it's a really nasty maternal metabolic condition that can really cause harm to the babies. Managing hypothyroidism, alcohol cessation, obesity control, and I suppose the thing that I spend a lot of my time doing is talking to people about teratogens in terms of, with MotherSafe. So for a lot of conditions, prenatally care might be a bit late, so we really try and, I suppose, shift back to preconception. So things like trying to stop smoking, although we'd say even if someone stops the minute they realise they're pregnant, that's still better than not stopping at all. Diabetes, genetic conditions and medication exposures. So again, just that emphasis on primary prevention, so saying, well, look, it's better to try and stop them happening in the first place rather than, I suppose, the search and destroy or, secondary prevention in terms of ultrasound and potentially termination of pregnancy. So the things that we sort of talk about, and we run clinics, and pretty much I'm going to talk about most of those things when I see a patient, even if it's just about medication, is, basic lifestyle issues of supplementing with vitamins and minerals, immunizations, medications, general medical history, health checkups, and family history and genetic issues. And then often the social situation and mental health is something that I think you guys would deal with a lot in your everyday interactions with your patients. So the sort of lifestyle things, and I'm going to skip over some of the things. I mean, I think I just heard the tail end of Sandra's talk, but talking about women who are underweight, and we probably see a lot more of those probably in the eastern suburbs than and around here than other people might, but there are certainly some risks of being underweight in terms of just the obvious nutrient deficiencies, but chronic, particularly women that have bulimia and a lot of purging, can end up with cardiac arrhythmias. There's issues with bone density, osteopenia, amenorrhea, and obviously infertility. And underweight women who become pregnant do have increased risks for both preterm birth and low birth weight babies. There's also a correlation between low pregnancy weight and increased risk of birth defects, particularly gastroschisis. And it was always said that babies were more likely to have gastroschisis if the mothers were really young, but that was probably a compounding of mothers with low BMI, smoking, possibly using things like cocaine and other vasoactive substances. And some studies suggest that there was a relative risk of up to 3 if a underweight mother had a baby with gastroschisis, and there was a sort of a a dose response, if you like, so that was reduced each unit of increase in BMI. And there's some evidence to say, well, even if you do gain weight in pregnancy, it may not necessarily overcome all the risks of a low pre-pregnancy weight. Again, there's just quite the eating disorders. Obviously, there's an issue about fertility, particularly bulimia seems to be less associated with fertility issues, but again, those sort of metabolic issues around binging and purging and abusing laxatives and diuretics. And there may be higher rates of miscarriage, low birth weight, and other obstetric complications in women with eating disorders. So again, I know that Sandra probably touched on a lot of this stuff, but the general recommendation is to calculate BMI annually and talking to them about fertility issues, particularly if they're not actually ovulating, and their longer term health issues, particularly in relation to things like bone health. And in terms of the other way around, we know that Indigenous women are more likely to be overweight or obese, and again that's an issue potentially with some of the women that we see through the Malabar Clinic in this area. And again, I think we're more aware probably of the issues around obesity and adverse pregnancy outcomes, and again that issue about pre-pregnancy BMI is probably a bigger determinant of healthy outcomes rather than what she actually weighs during pregnancy. And again, we know that the higher the BMI before pregnancy, the higher the associated risks. So things like birth defects. So we talk about a dose response with a higher BMI associated with greater risks, and particularly neural tube defects and heart defects. The other problem is not only is there a higher risk, and we say that there could be a doubling, so from a background risk of 3% up to 6%, but there's also those issues about the sort of what the ultrasound people euphemistically call, unfortunate maternal body habitus, so that it's actually harder to see the defects as well. So it's a twofold concern. And again, these are the sorts of, and this I suppose just shows that sort of dose response. So looking if you've got a BMI of 30 to 35, then if you, the risk of hypertension in pregnancy is about 5%, it goes up to 9.6% if the BMI is over 40. And you can pretty much see for all of these adverse outcomes, there is that dose response. And the green there is showing the sort of the ideal BMI. So just the sort of shopping list of all the adverse outcomes. We've got the antenatal risks, which include pregnancy loss, diabetes, hypertension, things like sleep apnea and a potential association with hypoxia, gallbladder disease, thromboembolic disease, babies that are either small or large, preterm birth, difficulties in actually feeling the baby in terms of abdominal palpation, and potentially maternal mortality. And in terms of sort of intrapartum and postnatal risks, anaesthetic issues, less likely to have a VBAC, more likely to have an operative vaginal or caesarean delivery, and the difficulties in terms of surgical access, shoulder dystocia, postpartum hemorrhage, other infections, breastfeeding issues, and again peripartum mortality as well. And from the baby point of view, NICU admissions more likely, need for blood sugar monitoring, particularly if the mother had blood sugar issues during pregnancy, more likely to have jaundice requiring phototherapy. Babies may be macrosomic, and again more likely to have things like palsies of the arms and fractured clavicles, congenital malformations, longer term, the sort of Barker hypothesis of obesity and metabolic syndrome, and some sort of, I suppose, somewhat questionable data around neurodevelopmental disorders, talking about ADHD, developmental delays and autism, and whether that's directly attributable to obesity is probably another question. And certainly respiratory problems such as asthma and recurrent respiratory tract infections. So again, the recommendations are really to enforce that optimising weight before and between pregnancies rather than during pregnancy, discouraging dieting during the pregnancy, really making use of things like dietitian services and that Get Healthy, which I've got the next slide about, screening for hypertension, type 2 diabetes, especially if someone's previously had gestational diabetes, and remembering that type 2 diabetes and gestational diabetes are really genetic, much more genetic than type 1 diabetes. So if someone's got a bad family history of type 2 and gestational diabetes, then that's a really, really red flag, I suppose. The other thing is for women who are overweight, with a BMI over 30, we recommend 5 milligrams daily of folic acid while they're trying to conceive until the end of the first trimester, because remembering that while most organs have sort of formed by 8 weeks, the palate actually takes a bit longer. It's about 11 weeks. So again, there's that covering that period. So pretty much it's easy just to say take it to the end of the first trimester. And again, supplementation with vitamin D, because obese women are at increased risk of vitamin D deficiency as well. So I'm sure you're all aware, but there is this program, the free telephone coaching through New South Wales Health, and they have got a specific access for pregnancy as well. So, and that involves, I think, 10 coaching, phone coaching sessions and a whole lot of other resources. So we're certainly recommending that to a lot of our patients that we see through the Plan Clinic and through our own Mother Safe service as well. So in terms of vitamins and minerals, I mean, there's always that question, should someone just take a normal vitamin or take anything special? Does it have to be the one that costs 3 times as much? I don't know, is anyone sponsoring? Sorry, anyway. And folic acid and iodine are in red because they're really the 2 things that are most important. I'm sure a lot of you see women who get pregnant and then are taking a multivitamin that contains quite a bit of iron and are feeling really sick early in pregnancy, and it's probably one of the first things that I see when I see people who feel really bad in pregnancy. Say, look, just unless you're, you know, really, really badly iron deficient, stop your iron supplementation, particularly when you've got really severe morning sickness, because that's not going to help. So there's probably quite good evidence to say, look, if you've actually got an okay diet and your BMI is in the normal range, you probably don't need extra multivitamins, assuming you've got an okay dietary intake. So folate and iodine are the 2 most important requirements, as I said. What people need to be aware of is that if you're taking a women's vitamin, it may not actually contain the recommended amounts of folic acid and iodine. So for example, one of the Blackmores, the Women's Vitality multivitamin, actually only contains 300 micrograms of folate and only 150 of iodine. So they're actually a little bit less than the recommended daily intake for pregnancy. So while people think that they might be doing the right thing, they may not be. So I suppose that is one of the things to emphasise, that the advantages of taking one that are specifically for pregnancy or preconception are going to have the right amounts of things. Another example of this one is it contains quite a bit of vitamin A, and 2,000 international units a day of vitamin A is actually the recommended daily amount, so that's actually okay, but people have a bit of a panic when they find out about that, so just to be aware of that. And most of the pregnancy vitamins are going to have vitamin A in the form of beta-carotene, which is the safe, non-teratogenic form of it for pregnancy. And yeah, as I said, iron really, the issue about iron, it's not about birth defects, it's about preventing anemia, so that's generally not an issue in the first trimester. And I suppose just the other thing, as the geneticist, I have to say, you know, beware of someone that's got, you know, is anemic and has got a microcytic anemia, that they're not a thal carrier and that it's not actually iron deficiency. So anyway, we'll get onto that in a minute. So again, folate, the recommendation is at least 0.5 milligrams for at least a month before conception. The people that need higher doses. I think the other thing too is when you're doing a sort of dietary history, there's a lot of sort of young girls who are really not eating much in the way of carbs. And while we've got fortification of wheat for the last 10 years, there's a lot of people that probably are not eating much bread, so they're not going to be getting much folate or pasta. They're not going to be getting much folate in terms of food fortification, which is why we're still really emphasising women should take folate when they're trying to get pregnant, but 50% of pregnancies aren't planned, so at least hopefully some people are getting some in their food. So the groups that do need higher doses of folate, and this is kind of a bit mine, so some of it people say, well, where's actually the evidence? But there's a few sort of, I suppose there is some consensus. So anyone who's had a previous affected pregnancy, whether it's spina bifida or cleft lip and palate, or any sort of neural tube defect, any family history, I mean, I suppose within reason, but probably there's not much evidence to say that taking a high dose of folate is harmful. So, you know, if you know about the family history, it's probably worth taking it. Yeah, women with a BMI over 30, women who have an abnormal blood sugar prior to conception, so type 1 or type 2 diabetics, people with MTHFR polymorphisms, and again, that's kind of, we're seeing more and more people. Most of the people who have the MTHFR tested as because it's at the sort of behest of their naturopath. So anyway, we won't go on. There's actually, if you want sort of evidence to say this is not fabulously scientifically robust, the genetics education have a very nice fact sheet on it. So have a look. People with inflammatory bowel disease or other people who may have malabsorption for whatever reason. And then there's certain medications. So we know about valproate and carbamazepine. It's interesting because with valproate, it was always said it was to reduce the risk of neural tube defect. And the data's not actually that convincing about that. But what has become apparent is that women who take high doses of folic acid and take valproate probably reduce the risks of having children with significant neurodevelopmental sequelae. So that's certainly something that is positive, and that's relatively more recent studies. So we're certainly, you know, not telling people not to take high dose folate with a valproate. Lamotrigine, and that makes sense, and we're seeing more and more women taking lamotrigine not just for seizures but for bipolar disorder. It acts actually as a dehydrofolate reductase inhibitor, so it makes sense for these people to take high doses of folate when they're taking lamotrigine. The other problem with lamotrigine is if you're taking it as an anti-epileptic, often women need to increase the doses during pregnancy because of the way they metabolise it. Women taking steroids, sulfasalazine and mesalazine, so, but then they've got inflammatory bowel disease, so that's another reason why they probably should be taking it as well. Cotrimoxazole, so occasionally women with things like chronic urinary reflux might be on long-term cotrimoxazole. Women taking atypical antipsychotics, I suppose we don't say it as a blanket, but often they are overweight. So, and some of them may actually have abnormal glucose tolerance. Methotrexate, but they should be taking it before they get pregnant. They shouldn't be taking methotrexate when they get pregnant. I put lithium down as a question mark, but interestingly, I've got a colleague who does the same sort of job as I do in Israel, and she also does tell people taking lithium to take high doses of folate. There have been a few studies of suggesting a higher rate of neural tube defects. So, and certainly that's confirmed in the animal literature. So there's some of the sort of common medical problems that, you know, need to be sorted and managed properly prior to pregnancy. We're seeing more and more people with chronic pain, and it's becoming quite problematic because there's a lot of things that, you know, they're told they shouldn't take, and a lot of them probably don't have a great management plan and get pregnant and then get a bit sort of upset when they're told that some of the medications they're on may not be ideal. So that's a group, and I think a lot of them probably do have underlying depression as well, but I think that's a group that we're certainly quite interested in, and we're seeing, I think, more and more through our service, and the pain service here at the hospital is as well, I think. So the things to sort of think about women who've got underlying medical problems are, well, what's the effect of the underlying maternal disease, whether the pregnancy is going to affect the disease, whether the disease is going to affect the pregnancy, and what's going to happen postpartum. And we know with a lot of rheumatological problems is that they generally get a bit better during pregnancy. MS is probably the best example of that, and most women, the majority of women with MS probably stop their medications when they realise they're pregnant or beforehand. But they're also aware that postpartum they're likely to have quite a significant flare, and so need to be aware of that, partly in thinking about what medications to be on once after the baby's born. Significant autoimmune disorders, particularly things like lupus, can actually cause uteroplacental blood flow problems and growth restriction. And so it's always that weighing up of the risks and benefits of treating, not treating, and whatever. I mean, the other good examples of what a disease, the sort of interactions between disease and pregnancy are things like migraine, because you can't always predict whether some people are going to get better or not. Some people's migraines that seem to be very sort of menstrual cycle related get a little bit better in pregnancy, some people's get worse. So again, it's having that plan and trying to work out what's going to be best. And things like steroids and cyclosporin, knowing that there may be increased complications that are going to happen in pregnancy anyway, but are more likely with certain medications. And so these are the sorts of things that might actually be related either to the medications or the underlying disease or the treatment. And so then getting on to the medications, and I suppose this is what I spend a lot of my time doing, is really weighing up those risks and benefits. And we'll just go through quickly, just saying, well, look, really, ideally we should be doing all this before people are pregnant. Often it doesn't happen, but it needs to be put into clinical context. And I really think, you know, it's certainly worth that conversation. And I think you guys do it really well. I think some of your, I hope there's no one here, but I mean, I think what I find worrying is people who've been through fertility services that, you know, are on chronic medications that have never really been discussed because they tend not to see their GP so much, and they start seeing their fertility specialists, and that kind of gets overlooked. And I think it's really important that those sort of discussions are had. So generally trying to reduce the number of medications. I mean, I saw a woman who was seeing a psychiatrist and she was, I'm not exaggerating, she was on 5 different antidepressants, 2 different antipsychotics, and you're thinking, well, I mean, she'd be rattling around, but really the polytherapy certainly significantly increases the risks, not only of not being able to predict teratogenicity, but more importantly, the sort of withdrawal and adaptation problems in the baby afterwards. So I think that, again, just really, you know, if one drug does the job, and you're much better off increasing the dose of one drug rather than adding more and more drugs. And we tend to, and I saw one woman who was on, she was on a really sedating antidepressant. So instead of thinking about maybe switching her to another antidepressant, she was put on dexamphetamine and all that, you know, so it was like, well, really, you're just giving one drug. So it was like crazy stuff. But so it's really just using, trying to be judicious about medications. And it's using the lowest effective dose. So there's no point halving the dose of something just for the sake of halving the dose of something, because generally it's not going to be safer in terms of pregnancy, but it's less likely to be effective. So the other thing just to think about is at the start of a pregnancy, you metabolise drugs normally, but as a pregnancy goes on, increasing circulating blood volume, increased renal excretion, often you do need to increase the dose of drugs. So just be aware of that. So staying on the same dose, say, of an antidepressant, so, you know, 50 milligrams of sertraline, if you've got a blood level of, I don't know, 5 at the beginning of pregnancy and you stay on that 50 milligrams, your blood level at the end of pregnancy is likely to be a lot lower, and you may need to increase that. And it's much better to increase that dose of sertraline to 100 rather than say, oh, you're feeling bad, you're feeling a bit anxious, let's put you on, you know, a bit of olanzapine at night, you know, and we see that a lot as well, unfortunately. There are some drugs that do need to be adjusted. Lithium's a really good example, anti-epileptics, and as I said, lamotrigine as well. In general, and it kind of makes sense, older drugs there's going to be more information about in terms of pregnancy, and really try and minimise over-the-counter and herbal preparations, because while the naturopath might tell you they're fine, you know, often there's not that much information about herbal preparations, not just about efficacy, but actually about pregnancy safety as well. And the whole issue about the timing. So some drugs might be okay at certain times than others. So ACE inhibitors are a really good example where we're not too worried if someone falls pregnant. I mean, we'd rather they got off it before they got pregnant. If they, got pregnant on it, we'd be quite reassuring, but say, look, get off it before the end of the pregnancy, before the end of the first trimester. So really, we try and be non-directive. We never counsel with regard to A to X categories or MIMS, so we really try and look at what's the data, individualised. So once they're pregnant, when did they take it? Was it oral or was it a topical, so retinoids, again, a good example. If someone took isotretinoin, you'd be very concerned. If they were using some topical retinoids, you'd be reassuring, but tell them to stop it. Why they're taking it, underlying condition, and really, as I said, up-to-date information. So just really quickly in terms of risk assessment, so 3% background risk, 5% if you include neurodevelopmental problems. So if someone says to you, I don't want it to have any risk, well then, don't get out of bed and don't have a baby sort of thing, because everybody's got a risk. About 1 in 8 recognised pregnancies end in miscarriage. So we see quite a few people who are really worried about a medication causing miscarriage, but it's very, very difficult to attribute cause and effect. And again, probably the vast majority of miscarriages are going to be chromosomally, caused by a significant aneuploidy. Really very few drugs actually significantly increase the risk of birth defects, so are true teratogens, and generally the risks related to a teratogen are going to be less than any sort of genetic risk like a dominant or a recessive condition. The main exception is probably isotretinoin, and that just leads me on to saying we've had a number of pregnancies this year where we've seen babies exposed, and this is just a cautionary tale of a girl we saw this year. She was 18. She was started on isotretinoin when she was 17. She went to her GP consultation with her mother and was prescribed isotretinoin, and abstinence, in inverted commas, was accepted as contraception. She had been taking 20 milligrams of isotretinoin a day till she realised she was pregnant at 14 weeks. She went to a private clinic for a termination, but she was actually 18 weeks pregnant, and the ultrasound there showed multiple anomalies, which included holoprosencephaly, a cardiac defect, and these were confirmed at the Royal, where she had a further ultrasound. So she had an induction of labour at 20 weeks, and these are just some pictures of that baby. So, I mean, it's really awful, and it's sort of confronting, but it's really just, it's a horrible drug, and really, and we, as I said, we've seen probably 10 women this year who've had it in pregnancy. So there's kind of problems in the message getting out. So I just, out of interest, so this baby had a cleft, it had this really unusual nose, sort of wide-spaced eyes, the low-set ears, which is very classic. And what's really interesting for the astute observer, this baby had very long fingers because the mother had probably had Marfan syndrome. So this baby probably also had the Marfan gene as well. That's just the geneticist. But anyway, but it's very interesting, but very tragic, and really just a really strong reminder about the prescribing of isotretinoin. So in terms of relative absolute risk, we say, look, and it's really how you frame things for your patients. So, and I think it's how you put it. So if someone really needs to take steroids for whatever reason, and really, that should be sort of backup rather than ongoing treatment, but relative risk of 3 of causing cleft lip or palate, but the background risk is only 1 in 1,000. So if you say, well, look, overall, your absolute risk is only 3 per 1,000 or 0.3%, that sounds a lot better than saying your risk is 3 times your neighbour's. So it's really how you frame it, and it again, probably even paroxetine, which is, most people feel a bit uncomfortable about. If you say, it's the antidepressant that's the most likely to cause heart defects, it's double the background risk. So instead of 1 per 200, it's maybe 2 per 200. It's still not 50-50. So, you need to put it into context. And to be honest, if paroxetine is the best antidepressant for her, she should stay on it. So serology and immunisation, checking status, remembering it's only 28 days. We're still seeing a few people who've been told to wait 3 months and get really upset when they fall pregnant within that 3 months. And again, remembering, don't check antibody levels to varicella post-vaccine, because if they're negative, it's meaningless. And we're going to be seeing a bigger cohort of, people who were born after 1994 or whatever, who are going to have been vaccinated. It may be reasonable to check serology for CMV, toxo or parvo, but don't do it when they're pregnant unless you've got a really good reason. And really, and hopefully you've all seen all the stuff now about CMV and the Department of New South Wales Health, and there's quite a nice pamphlet really about prevention, because even if you're immune, you can still get reactivation. We talk to people who are in high risk groups, so childcare workers and nurses, particularly about the prevention. And so again, just the vaccination, flu vaccine, RANSCOG, Ministry of Health, everyone says they should, any time of pregnancy, think about for the partner as well. That's just common sense. And the pertussis is now from 28 weeks. And cocooning, people still talk about it, but it's less important if the mother's vaccinated. And then these are just other things that people might want to think about. So infection screening, sexually transmitted diseases, fasting blood sugars if there's a good reason or significant history, thalassemia screen. And even when we're going to talk about genetic testing, full blood count, iron studies and thalassemia screens, and HbEPG is still the best way really to screen for thalassemia carriage. And medical history, which is all pretty fine. These are the sorts of metabolic problems, which again I've sort of talked about. Dental checkup, we really talk to people about that. And there's increasing evidence about low-grade infections. So people look at me strangely when I say, yeah, it's worth going to the dentist. And if for no other reason, it's really awful to go to the dentist when you're pregnant because you just, ugh. Anyway, I hope there's no dentist here. But we're really trying to encourage that too. So the other things just to talk about before we get on to the genetic screening. So advanced maternal age, just sort of talking about what it involves and that actually it might be harder to get pregnant as you get older. People who've had a previous abnormality or loss, if there's a family history, parents who are consanguineous. And I suppose we're offering consanguineous couples more genetic carrier screening because we can now. So just to get on to carrier screening. So you may be aware, so there was a study that they did in Victoria and they looked at about 12,000 couples, and really what they found was that 88%, so 94% of them had couples testing, so about 5%, about 1 in 20 people actually carried at least one of their conditions, 8 carried 2. Because it was looking at Fragile X, they prioritised doing the women first. And not surprisingly, about 88% had no family history. So while as a geneticist, we go on and say, you have to ask about family history, it's not going to be particularly relevant for recessive problems. So in this, they found that 50 couples were actually at risk of having a child with a particular problem, and 32 were actually pregnant at the time of the testing because they offered it to people preconception or in the first 12 weeks of pregnancy. And 26 of those opted for prenatal diagnosis and 7 affected pregnancies. So kind of what you would expect, but nevertheless it's kind of worth doing. And what they kind of emphasised, well actually the combined affected pregnancy rate was comparable to the population risk for Down syndrome. So while we spend a huge amount of time and effort screening for Down syndrome, we should be thinking more broadly about carrier testing, although we know that these are lots of different rare conditions rather than 1 or 2 more common ones. And also emphasising that people need to know about screening and support and how to actually counsel people. So people were aware of this couple, so the Casellas, and they had a little girl who was actually born at this hospital with spinal muscular atrophy, and they lobbied and ended up kind of galvanising the government really to spend a lot of money on genetic testing. And Mackenzie's mission you may have heard about, and that's about to actually start recruiting very soon. And so it's the first project funded from this huge $50 million pot of money that was given to the for this Genomics Health Futures. So the plan is to screen 10,000 couples either in early pregnancy or prior to pregnancy, and really as a pilot to see how can it be actually rolled out in the future. And so they curated, they went through like every single possible recessive or X-linked condition, and they came up with 1,700 conditions that are going to be screened. They're going to report the couples as at-risk couples. They're not going to be giving people individual reports, which some people, like me, find it a little bit problematic. The reason is logistics. So it means that you're not going to be doing cascade screening because you don't know which of the, if it's the male or the female, and therefore their siblings. So we're not going to be doing that. But there are issues. So if the couples separate and repartner, they think they've had genetic screening, and then so there's a few little issues. But because of the number of conditions they're looking at, that's the way they've sort of argued is the only sensible way to do it. Couples who are at risk, so meaning they both carry a fault in the same gene, are going to be offered a free cycle of IVF and PGD if they want that. And this site, so the Royal, we're going to be recruiting people, I think, starting next year. So people will be given information and support, and it's going to be very well studied. It's going to be looked at in terms of psychology and ethical issues and economic benefits, I suppose, and really with the aim of saying, well, how can we implement it in the future for everybody? And it's going to start, as I said, here and in a couple of other states later this year. You're probably all aware that in March of this year, the College of ONG came out with sort of fairly, I think, quite progressive statements and recommendations around carrier screening. So just quickly going through saying, well, look, all couples who are intending to have children should have a family history taken to identify relatives with heritable genetic disorders, and also to make sure they're not consanguineous. And that's kind of not new, and that they should be referred to genetic counselling about carrier testing and prenatal diagnosis. The second one was about thalassemia, which we've talked about, and again, doesn't matter what other sort of carrier testing, that's what they should have. And I think you can't assume ethnic background either. So I've seen a number of people who've been alpha and beta thal carriers from sort of backgrounds you would not necessarily have thought about. And I always talk about a friend of my son's whose last name is Wong, and he's the most blonde child that every time he was in a waiting room, the mother would say, oh yeah, this is child Wong, and he'd get up and they'd say, no, it's not that child. No, but the father was Chinese. So you can't assume, that's what I'm saying. So, and that people need to be offered carrier screening to all women planning a pregnancy or in the first trimester of pregnancy. So that's a huge statement, I think. And options for carrier screening include screening with a panel, so things like the three that the VCGS looked at, the PREPARE, if you like, the cystic fibrosis, SMA and Fragile X, or screening with an expanded panel that contains many disorders, up to hundreds. And for individuals of Eastern European or Ashkenazi Jewish background, to discuss Tay-Sachs and some of those other conditions. And then these sort of other recommendations said people wanting more information should be able to have a more detailed discussion about that with an informed clinician. I don't know who they mean by that. Whether that's, you know, a GP, a genetic counsellor, obstetrician, probably not. I hope there's none here. But informed consent for screening should be obtained, and include any out-of-pocket expenses. And as you're all aware, all of this is not covered by Medicare, so there are going to be out-of-pocket expenses. And then they also talk about labs only reporting status for what we think are pathogenic variants or mutations, not things of unknown significance. And couples who are at high risk of having an affected child should be referred for genetic counselling. So basically, these are the sort of options, and just, I'm sure some of you are aware of what's around, but so Invitae is one that I think is actually a really nice one, and we're using that quite a bit now. It looks at about 300 conditions. A doctor can order it, but release the patient's results to the patient. You can customise it, so you can do as many or as few as you like out of the 300. It costs $250 US, so about $400 for a person. And if the partners, there's sort of an add-on, it's another $100 US. So it's not unreasonable. The VCGS only looks at 3 conditions. Any doctor can organise that, and essentially costs about the same. So I sort of say, well, you certainly get more bang for your buck with the first one. Whether that's good or bad is another question. The Jewish community screening. So I suppose till recently, Jewish women had more carriers testing than anyone else because they were offered things like Tay-Sachs and cystic fibrosis. But that's kind of fallen by the wayside. So the Jewish women are now really just getting the Jewish conditions and cystic fibrosis. So they're not getting Fragile X and they're not getting SMA. So in fact, they're missing out a little bit. And we're actually talking about how we can improve that for the women that do go through the WALPA. And then there's other panels. So there's one that, you know, patients who go to IVF Australia, and if they're using a sperm donor through IVF Australia, those sperm donors are now having a 550 gene panel, which, about probably 70% of people who have that are going to be found to have something, not surprisingly. So Invitae, as I said, that's the one I quite like. That's what the result looks like. And I think it actually is quite nice. So it tells you what you're a carrier of, it tells you that it's recessive, and it tells you whether or not you should actually get the patient's partner tested. If it's an X-linked condition, they wouldn't bother because it's not relevant. And it tells you a bit about the condition. And what's nice as well is at the bottom, if you can see there, it says, well, if you're of whatever background, this is your carrier frequency in that particular population. So if you're an Irish gypsy, you're 1 in 11 chance of being a galactosemia carrier, but if you're Ashkenazi, it's one of the few things you're probably protected from. It's only 1 in 156. So it's it's potentially useful for people in terms of, and then they'll say, look, pan-ethnic, so just, if you don't really know, it's about 1 in 100, which, so I think it's actually quite nice, and I think the reports are really nice and clear. So I'm not sure if any of you are aware of it, but there's something called Eugene, and we're starting to really encourage people to use this. So it's an online test. It's a saliva test to send out to the patient, and then they get a thing to send it away. And they basically do that Invitae test. So they send it off and they get this sort of thing. But what the patient gets is an app, and they get counselled, and it costs $479. So if you do it yourself, depending, I suppose, on the day of the exchange rate, or if you do, if I do it for a patient, they have to get their blood collected here. It's a bit of a pain, or they spit in a tube, but then they've got to ship it themselves. So this kind of includes counselling, and it includes them kind of doing everything. What's a little bit, I suppose, dodgy is that if you do it up front, it's $479 as an individual. If you do it as a couple up front, it's $679, which is okay. But if you do it, so it's hedging your bet. So you're saying, well, 50-60% chance one of us is going to be a carrier. We normally advise the woman to do it because it's X-linked. So if you do it up front, it's $679. But if you're saying, well, I might actually save a bit of money, you may or may not, because if you're a carrier and you want your partner tested, they give you $50 off, but they basically charge you twice. So it's kind of, it's, I suppose, how people, it's like going to the races, I suppose. But anyway. But that's the website, and it's actually really nice. So yeah, certainly we're using, we're sending a lot of people that way. From our point of view, so this is, we've sort of put this together here at the Royal. So essentially saying, look, if someone's got a family history, they should go to genetic counselling. If there's no family history and they're less than 11 weeks pregnant, talk to them about carrier testing, and that's sort of that big thing here. So in the middle, you're not actually seeing my thing. And then if they're pregnant and one of them is a carrier, then you need to send the other one off. And then if they're both, and if the pregnancy's at risk, then refer them for invasive testing. If they're not at risk, then they can go on their merry way. So really, if they're planning, refer the woman first because of the X-linked conditions. Statistically, 5% of individuals are going to carry one of the three, and about 60 to 70 people are going to carry at least one of the 300 on Invitae. So that's, ballpark. And in fact, it's probably not that much higher with the 550. It's probably 70 to 80%, but certainly not 100%. If they're already pregnant, then you should test them both at once because there's kind of a time factor there. And we don't generally offer testing to women over 12 weeks of pregnancy just because of the logistics and, they're going to be anxious. So if she's a carrier of an autosomal recessive condition, she needs counselling and her partner needs to be screened. And you should also discuss cascade screening and first-degree relatives. If it's cystic fibrosis, that's actually covered by Medicare, but the others are not. If a woman is a carrier of an X-linked condition, then she needs counselling about her reproductive risks and, again, issues about cascade screening of first-degree relatives. Fragile X is complicated and certainly needs sort of referral for a discussion with the genetic counselling because it's quite complicated in terms of expansion and all those sorts of things. So couples at risk, if they're both pregnant, if they're already pregnant, then we can offer them invasive testing. Some couples are going to decline that but do want the baby tested at birth with a cord blood. If they're identified as at risk prior to pregnancy, then again they should be referred for counselling and to have a discussion about if they fall pregnant, considering prenatal diagnosis. If they don't feel comfortable about the idea of termination of pregnancy, then considering IVF and PGD. They're expensive, and just to be aware that even if they have private insurance, IVF will be covered to a degree by Medicare and their private health, but the PGD, so the genetic testing component, won't. So in summary, they need to understand what the pros and cons are, and it's, I suppose, the whole issue about carrier screening. It's just part of that whole approach to preconception care. So just in the last minute, just to make everyone aware that we've got a website, so hopefully you all know about our website. We've got a lot of fact sheets, we update them. And if anyone wants any if anyone has any suggestions, we're happy to. We're sort of a bit stuck now. We're thinking of what more. So if anyone has some burning ones they want us to write, we'd be happy to do that. Also, just a little plug. We've had some students here from Norway who are interested in an app for nausea and vomiting decision making. So tell your patients they can just click online through our website. And then our Plan Clinic, which now is at Karitani at Bondi Junction, and we've got sort of low-risk women. Really, it's run by a very experienced midwife, now actually Deb Blackwood, who used to be the GP Share Care midwife. And so drop-in or appointment. So really just going through that checklist, really discussing about models of care here at the hospital, and really emphasising the importance of engaging with one of you guys rather than sort of not having a regular GP. We don't order any blood tests, we just say these are things you should discuss with your GP and often guide them. And sometimes we do actually refer them to other clinics at the hospital. We've also just recently set up a complex preconception clinic, and that's with women with complex problems. So it's not just diabetes or one single problem. So these are really, really complicated people. So women who've had heart, lung transplants, lupus nephritis and cancer, and really, really weird and wonderful things. So it's a monthly multidisciplinary clinic. It's every second Tuesday afternoon. Every second Tuesday of the month. And there's Amanda Beach, who's the obstetric physician, Antonia Shand, who's the MFM person, me, and another midwife. And patients need a referral, and then we kind of triage them about who they see. So they might see one or all of us. And these are just some useful websites. You've seen ours. Bumps is quite it's a British one, so it's quite good for like individual medications. Lactamed, hopefully you all know about, it's great for breastfeeding. And the Centre for Genetics Education has some really nice fact sheets about lots of things, including prenatal diagnosis. And if you've got a particular genetic problem, Gene Reviews is really nice. And that's it. Okay.